Well, good morning. This is Gary Tier, who's CEO of the Health Quality Council, and I'm welcoming you to QI Power Hour, and a special welcome to those who are joining for the first time. So QI Power Hour is a free monthly WebEx offering hosted by the Saskatchewan Health Quality Council to provide an opportunity for colleagues across healthcare, as well as other industries, to hear from local and national improvement experts on a variety of quality improvement-related topics. So just a reminder that following today's session, a recording of the event will be posted to our Health Quality Council website. And you can share that out with colleagues who are not able to join us in person today, or refer back to that if you didn't catch everything you wanted to catch the first time. We also invite you to check out the other recordings of presentations of past sessions, which are available on demand at the address listed on your screen. And while you're on our Health Quality Council website, I invite you to sign up for our distribution list so that you'll be sure to receive regular invites for all our upcoming QI Power Hour sessions. And feel free to explore the website further to see what all Health Quality Council is doing. So over the past number of months, we've been delighted to see how QI Power Hours has continued to spread through our province, within our provincial healthcare system, as well as to other organizations in Saskatchewan who have an interest in quality improvement. And we've also begun to see spread to other organizations within Canada and even abroad. So again, everyone, welcome to QI Power Hour this morning, or whatever time of day it is where you're calling in from. I'll now pass it over to Chelsea Schwartz, Provincial Improvement Consultant here at HQC, to cover a few of the interactive functions involved in today's webinar. Chelsea?
Thanks so much, Gary. As Gary mentioned, I just want to remind folks of the different ways they can contribute to today's session. So the first feature I want to highlight is the annotation function. You can access this function by clicking on the pen icon on the top left-hand side of your screen and then selecting the arrow icon. So I'll give everyone a moment to locate those tools, and then I'll invite you to practice using that tool by indicating on the map where you're joining us from today. Thanks, Francisco, joining from Manitoba. Thanks, Brenda. Oh, we have Brandon Bennett joining us from the States this morning, our guest speaker. Nicole, welcome. Kathy, looks like our local folks are representing well this morning. Amir, Tracy, Rafiat, Mary, welcome. So it looks like everyone has a hang on that. So I'll also just introduce you to the chat function today. So just a note that we're trialing something a bit different today. So for those of you who have been part of previous QI Power Hour sessions, you may have noticed that you don't see the Q&A function today. And so for the reason for that is that we want to funnel all of our activity this morning through the chat function. So you'll find the chat function on the top right-hand side of your screen, and you can click on the message bubble to share your questions, comments, and ideas throughout the presentation. We'll have some dedicated time with Brandon for Q&A at the end of today's presentation. And we invite you to send all your questions to all participants. So in the drop-down menu, you'll notice that you can send your question to a variety of folks, but we encourage you to send it to all participants so that we can build on the discussion, build on the questions, and really get that sense of community on the call this morning. If you're experiencing any technical difficulties, you'll notice that we have some tech support. We have Lorianne here manning tech support, so if you have any questions to that effect, I'll invite you to connect with her and she can help you resolve your issue. So let's take a moment to practice the chat function by typing in the name of the organization you're joining us from this morning. So a reminder to select from the drop-down menu all participants, and then type in the name of the organization you're joining us from. Prairie Mountain Health, Manitoba, Public Health Agency of Canada, Alberta Health Services, Manitoba Health Primary Care, hello to Liana from Manitoba, our neighbors here down the hall from HQC. Perfect, looks like folks have a good handle on that. So the last tool that I just want to highlight before we get started this morning is Twitter. So if you are a Twitterer, we invite you to log on to your Twitter account and tweet out during the session to share your learnings. You can use the hashtag QI Power Hour and the handle HQCSask. And Brandon, our guest speaker this morning, has also added his handle there if you want to tag him in your posts as well. So I'll pass it back over to Gary to introduce our speaker for this morning.
Thanks, Chelsea. So I'm delighted to welcome this morning Brandon Bennett. He's going to be speaking to us about thinking upstream, intersectoral quality improvement for health and wellness. And Brandon is has been a faculty member in our quality improvement consultant school, our clinical improvement quality, gosh.
Clinical quality improvement
program. Yes, I'm all confused here. So Brandon is no stranger to Saskatchewan. He's been here before and worked with our people here. He began his career as a United States Peace Corps volunteer, completing his service in Uganda. He worked alongside people living with HIV and directing a continuously improving microfinance program in an effort to create sustainable finances for business, assisting those in poverty. He served as an improvement advisor in the fields of healthcare and education, leading and advising on a diverse initiatives from disease-specific processes to countrywide improvement programs. Brandon has also published on the application of improvement science methods and has been a featured speaker at quality conferences around the world. He's currently a senior fellow at the Carnegie Foundation for the Advancement of Teaching and faculty for the Improvement Advisor Professional Development Program offered through the Institute of Healthcare Improvement. And as I said, he's also on our Quick School faculty here. So without further ado, I'll turn it over to Brandon, and we look forward to your talk.
Well, thank you, Gary. I appreciate it. And good morning, everybody. It's wonderful to be with you. Very much looking forward to our call today and to our session. For many of you, I suspect, who have worked in public health settings or in global settings of different types, a lot of what we will talk about will feel or be very intuitive. I don't think it's a new idea to sort of work upstream on the problems of health and in populations. But what I will be talking to today a little bit is a couple of examples of how improvement science and quality improvement ideas are starting to intersect with what I would consider to be cross-sectoral change. And so we'll be looking at 3 different case studies today. In particular, we're going to be looking at one in Alabama, in the southern part of the United States, one in New Zealand, and one in Cincinnati, Ohio, in the central part of the United States. I wanted to start off today with this quote by Michael Marmot. Michael Marmot is a physician and leader of the Commission on the Social Determinants of Health for the World Health Organization, and he had to say this in 2005, that reducing social inequalities in health and thus meeting human needs is an issue of social justice. And I think this idea of social justice is a critical one for us. I think when we look at the health outcomes for our populations and for individuals who pass through our health institutions, this is something that sort of weighs on many of us, that the care we provide, we want it to be the safest care because that's an issue of justice. That's a moral issue that we grapple with. And as we start to consider not just things like infection rates and injuries in hospitals, but we start to consider the broader health of populations, that continues to be an issue, particularly one of equity as we start to segment our population into groups that have access to services and those that have less access or have no access in some cases in some parts of the world. And so this is an issue that's near and dear to my heart. I've been working in public health settings for the last 15 years or so, and really have been interested in how we provide more equitable care, how we provide more accessible care, more efficient care for as many people as possible. And in particular, how we can prevent the need for care by keeping people healthy and engaged in productive lives that are happy for them. And so my work over the last 15 years, as Gary mentioned, has really focused on both health and education. And at the moment, I'm really excited to think about how to put those together along with judicial circuits, with social welfare organizations, and with a variety of other stakeholders across communities who have a very similar interest, understanding that all of these things interact with and intersect with each other in individuals' and families' lives. So as I said, we'll be talking through a variety of things, variety of case studies here. But importantly, I wanted to start with a little discussion of what the social determinants of health are. And the World Health Organization defines these things pretty broadly, and I think in Canada, there's been some more specificity that has been involved in defining the social determinants of health. But here is a long list on your screen, and we're going to refer back to this slide after each case study to sort of look at how each intervention or set of interventions, how each activity is interacting with this list of determinants of health. I think for those of you who are looking at this, you'll realize that all of these things can have a profound influence on the sort of health and well-being outcomes of individuals. We know, for example, from the field of education that access to early childhood education and early childhood development has a profound effect on whether or not someone ends up completing high school, attending university, whether or not what their sort of long-term financial income will be. And we also know from the field of healthcare that that nutrition in the first 2 years of life has a profound effect on the developmental outcomes of a person's life over the long term. So this is one example here of a social determinant that has really, really profound effects on folks. And of course, there are so many others, and we'll look into them in greater detail in just a moment. As we go today, as we go through our case studies, I'm very happy for you to chat questions into the chat box. I know Chelsea is going to be monitoring those, and certainly if there's something urgent, she'll interrupt me, and we can certainly pause and deal with that. And of course, at the end of the call, we'll have a broader discussion. So please do take advantage of that, and we'll look forward to hearing. But we're going to start off today with a case study on crime prevention in Alabama. It may not seem like the closest thing to a health intervention that you've ever heard of, but I would argue that it actually has a profound impact on the health of communities in the state of Alabama. And let's just jump down to how these different cases are going to unfold. So one thing I want to talk about is the methods that these cases employ. And so in each case, there will be elements of improvement science at work. One of the things that I believe very strongly is that in order to improve systems, it's not enough to just be focused on the subject matter expertise, on the sort of, if it's in medicine, on the clinical knowledge of medicine, if it's in public health, on the knowledge of health education, or if we're in the field of education on whatever subject in particular that a teacher might be wanting to or needing to deliver in the classroom, but rather there's a variety of other aspects of knowledge that we really need to understand deeply in order to improve systems. And you can see those there on the left-hand side of your screen, that we really need also to understand variation. We need to be able to use data effectively as a window into a system's performance or a community's performance around a metric of interest, whether that's health or education, financial outcomes, et cetera. We have to understand something about the psychology of change, that when we are seeking to improve on a particular outcome, that we're asking people to live and work and behave in different ways, and so we have to understand something about how to help them change their way of being and how to do that in a way that's positive and not detrimental to their well-being in the process. We have to understand something about how systems are designed and how they're put together, believing very strongly that the complex dynamic nature of systems has a profound influence on outcomes. And we have to understand something about learning, and in particular, having theories to drive learning forward. And all of this has to be based, going back to Marmot and others, on our values, whether or not we really believe or see health and well-being as an issue of social justice or as a moral issue for ourselves, for our time, for our communities. And so applying these ideas in practice becomes profoundly important, and not just sort of thinking about them philosophically, but finding pragmatic ways to enact them in the environments and communities and systems where we work. And of course, in many cases, and in the 3 cases we'll see today, the utilization of theory-based learning is a critical component of that application process, about sitting down together with a team of people, stakeholders, community members, deciding what's important, identifying key leverage points, and then trying change in practice in order to discover what works for who, when, and where in our systems, and continuously refining our understandings and our beliefs and our evidence base in order to get there. So we're gonna have that as a backstop, and in each case we'll see different applications, whether it be application of theory-based learning, whether it be understanding variation or application of systems thinking, et cetera. We'll be looking into that. But let's jump down to Alabama for a moment. I wanted to start off here because I think it's a very interesting initiative. It's an initiative called the Helping Families Initiative, and it was started in 2003 by a man named John Tyson, who was the district attorney of Mobile County. And for those who are unfamiliar with Alabama in the United States, Alabama is a state in what is considered the deep southern part of the United States. In terms of outcomes, it ranks pretty low. I think in terms of high school graduation rates, it's somewhere around 48th in the nation. In terms of literacy, it's also around 48th or 49th in the United States. Historically, this is a state that has been relatively to extremely poor, and there is a fair amount of extreme poverty that exists there. It's also a state that has had a long history of inequality, and this is a state where the civil rights movement really got going and has tried to address issues of race inequality over the last probably 50 or 60 years, and is still seeking to address that. But I think in this particular case, what you have is a district attorney who generally tend to be pretty conservative, who generally are focused on the enactment of the law and enforcing the law. You have a district attorney who, after 10 years in office, was very frustrated that over and over and over again, his job was to prosecute essentially young black men for crime. And these were men who were between the ages of 18 and 24 for the most part. And what he thought to himself at that time was that these young men's lives, by entering the criminal justice systems, were forever shattered. That they would have an inability to participate in society fully after a conviction. So once being convicted of a crime, and particularly if that crime is a felony, you lose things like the right to vote. It becomes exceedingly difficult to have meaningful employment after incarceration. Your lifetime earnings are depressed, and the recidivism rate for committing crime is exacerbated by criminal prosecution. So John Tyson thought to himself, here's a situation that's not good for the health of my community and for our society at large. What could we do about this? How could we prevent crime? And his thinking was that there were people in the lives of these young men, primarily young men, whom he was prosecuting, who knew maybe 5 years ahead of time or 10 years ahead of time that this particular child's life was getting off track as far as sort of societal norms were concerned. And that if we could identify early in the life of an individual when things were starting to go bad, we could intervene early before there was ever a major crime committed or the need for a criminal justice system to become involved in a person's life. And so John partnered with a social worker, which is a pretty extraordinary move. And he partnered with a social worker named Jane Carson to see if they could create a pathway for intervention that would assist families in need early on. And so that's what the Helping Families Initiative is. And it has a vision here, which is to reduce recidivism among suspended students by 85%, and or to reduce chronic absenteeism in schools by 50%. So it's interesting. So as John and Jane started to think about this, they moved upstream into the school system as a key place, understanding that teachers who see students every day are likely to be the best people to understand if and when a child's life is getting off track. Secondary aim they have is that 75% of children enrolled will demonstrate positive changes in the child well-being score within 120 days of program entry. And that's indicated by a 2-point movement on something called the North Carolina Family Assessment Scale, which is a tool for assessing family stability that is used widely in the United States and is used in Alabama, obviously developed in North Carolina. So they have a theory of what to do. They have a theory that involves engagement with families, that involves making sure that families who have needs have those needs met, that involves equipping families with the knowledge they need to successfully navigate the complexities of life, you know, that when they're communicating and interacting with one another. And so they have a strong theory of that, and they have that articulated here as a driver diagram. For those who are unfamiliar, this is a tool that really allows, a visual tool that allows a team, in this case the Helping Families team, to say, here's our shared understanding of what it will take to achieve our aim, our sort of outcome of interest. And through this, they have developed an intervention pathway. And I'm not going to go through everything in detail for you here, but I want to highlight a couple of key things that they have been able to do. Remember, this is all happening within a district attorney's office, which is traditionally charged with the responsibility of prosecuting the law. I'm going to use my pointer here for a second. The first thing, this first big circle, right where we start, and there's sort of a unique situation that led the district attorney's office back to the school system as a point of intervention. And that is, in 1927, there was a law passed in the state of Alabama that states that if a child becomes chronically absent, and that's defined as having 5 or more unexcused absences from school or 10 or more excused absences from school, or that child is suspended for a serious offense, like a physical assault or something like that, bringing a weapon to school, that type of thing, then that child and the principal of that school, by law, must be referred to the district attorney's office so that the district attorney can then decide what to do. That's a very strange law to be enacted in 1927, but the result is that nearly 100 years later, we have access to information at the district attorney's office level about which children and thus which families may be experiencing systematic hardship, right, that may be suffering as a result of all of the different social determinants of health that we started the call with. And so there is information available at the district attorney's office. And so the first step in sort of intervening in these child and families' lives in a positive way and sort of helping them to get back on track is identification, and the law helps with that. The second major step and the big sort of intervention breakthrough, I would say, that occurred is in the initial family visit and assessment. And this is where embedding a social worker in the judicial circuit, in the district attorney's office, became really critical. So now there is a situation where a social worker can go and meet with a family of a referred child and can ask a question. It's not mandated, it's not mandatory, there's nothing forced upon families. But social workers can reach out to referred families and ask a very simple question: what do you need? What do you need? And if the family is open to connection, then the social worker will meet with them in person, and they will move through the North Carolina Family Assessment together, and they will co-create a plan of action. And so what's really important there is that it's by invitation only. It's a pull system where families say, yes, we would like help. We would like to meet with somebody. We would like a plan for how to get back on track as far as our child's attendance in school is concerned. We have some needs, and here they are. And for the social worker to not foist upon a family their view or vision of what's happening, but to co-create that with the family. And so that takes place, and what ends up happening is that an identification of an intervention plan is done, and then that work goes on. And the social worker acts as a care coordinator, a navigator for the social welfare environment is what I would call it, where some families might need help with housing, some might need help with food security, early childhood education services, child care services, job placement, et cetera. And so the social worker then acts as a navigator for all the different services that a family might need in order to achieve greater stability. And every 3 months, what happens is the family reassess with the social worker how they're doing. And they recreate the North Carolina Family Assessment Tool, and they look for a change in score on the child well-being components of that assessment. And if after 3 months more time is needed, more intervention is needed, then the process circles back on itself. If after 3 months things are going well, or after 6 months things are going well, after 9 months things are going well, then the case reaches closure and the student and family sort of exit the Helping Families initiative. And so this is sort of a profound experience where you have a relatively low-cost, high-impact intervention in an unusual place, the judicial system, that actually has a profound impact on the health and well-being of the community. Some of the activities or some of the measures here we won't go into in too much detail, but they do have a measurement system. And if you're interested, we can talk about this more at the end. But they have lagging outcome measures like prosecutions and leading outcome measures like case closures. But some of the results that they've had that I'd like to highlight for you are pretty profound. From Mobile, they have now spread to Montgomery and a variety of other judicial circuits. And in Montgomery County, they have seen 80% of students in that school system have not been suspended again in the next 12 months for any reason, which they consider a big success. They have reduced unexcused absences, or sometimes we call that truancy, by 24%, which is incredible. And school suspensions were down by 30%. And for those who are unfamiliar with the U.S. school system, this last statistic of reducing suspensions by 30% is particularly important because suspensions hit children of color at a rate of 4 times to 1 of that of children who are white. And so this is a massive improvement when we consider the long-term outcome of suspensions and expulsions from school. So the list goes on and on, but we've had some really, really spectacular outcomes here with Helping Families. And at the moment, they are now at a place where they have done a good job of codifying what it takes to create an effective intervention system and are in the process of now trying to go to scale across judicial circuits in Alabama and are indeed exploring opportunities to expand into other states and other judicial circuits in other states. So the social determinants of health that this particular initiative does a good job of addressing, in my opinion, are things like income and income distribution, education, unemployment and job security, early childhood development. I think race in particular is here. I for some reason have forgot to embolden that here, but I think that they do a good job of understanding that the justice system and the school system have really been skewed towards prosecution of men of color and have dealt with that head on. And so they are seeking to sort of change that by moving upstream in what they do. All right, I'm going to move on to a slightly different initiative, which is not in the judicial system, but is based squarely in the healthcare system. So coming closer to home for many of us. This particular case comes from New Zealand. I've had an opportunity to work in New Zealand a lot over the last 6 or 7 years, and in particular with Counties Manukau, which is a great organization based in South Auckland. And Auckland being the largest city in the country, this particular health district board serves about half of that city. And it serves the half that is primarily of lower income. Its flagship institution is a hospital called Middlemore Hospital, which has about 800 beds, 24 operating theaters, 4,800 staff, and sees about 8,000 emergency room visits each month. And what I wanted to note is that on top of that, there is another sort of maybe 100 plus primary health care providers in the county's environment who provide health care at the primary level to folks. And one thing that has been noted by counties is that there are a lot of emergency room presentations by people with chronic care conditions. And this is particularly is becoming an increasing burden on the system, right? Emergency rooms really being meant for acute issues, but unmanaged chronic care conditions can result in acute flare-ups of things like gout or ketoacidosis or any number of other conditions. And so, out of one of these primary healthcare institutions, East Tamaki Healthcare, they decided to sort of see if they could change that, if they could work upstream to dramatically reduce ED presentations amongst their chronic care patients. And they sort of recognized up front that people have long-term comorbid conditions and mental health or addiction issues have generally poor health outcomes. And so they started to look at what they might do. And they came up with a program called Kaha. Kaha is a Maori set of words that roughly translates stronger together. And this intervention really focused on trying to reduce, as I said, unplanned emergency department presentations by 25% in participating patients. The intervention really focused on achieving engagement and activation connection with what are called hard-to-reach patients with long-term chronic care conditions. Hard to reach is sort of a euphemistic term for patients who don't show up for their appointments and who don't necessarily have good adherence to their medication protocols, and so are considered hard to reach. But you can read into that from a caregiver's perspective that these are patients that many caregivers would find very frustrating to work with. But in this case, East Tamaki Healthcare, the primary care provider there, David Kadaya and Leona, worked together to say, what could we do differently? What could we do differently to meet the needs of these people? Because the system as we have set it up, the primary care system, is not working for these people. It's not doing what we had hoped it would or intended that it would. And so they looked at developing Kaha as a way to meet the needs of people for whom the system is not well designed for their needs. And so they looked at, first and foremost, the provision of peer support. And this is perhaps the biggest breakthrough that they had was in figuring out that creating peer support groups and providing in-home peer support had a profound impact on whether or not people with chronic care conditions ended up in the emergency room. And in particular, they had a theory, and what they were learning about their theory is that it was a pretty good one, that people with long-term chronic care conditions in their community tended to suffer from two critical issues that did not necessarily have to do with their health outcomes directly, but indirectly had a profound influence. One of those was loneliness. A lot of people who had chronic care conditions felt very isolated in their communities. They felt homebound in many instances. and felt very lonely as a result. And critically aligned with that was that many were depressed. And so the lack of social connection really put them in a place where it was difficult for them to take advantage of services in the primary health care clinics or in the community as a whole. And so their intervention here with peer support was to get people back engaged with each other and to connect people. And so they had trained peer supporters who could go from house to house and who could assess people for their sort of on a depression index and could understand if some needed psychiatric support in the form of medications, or if what they really needed was participation in group support and counseling and these sorts of things. So they offered individualized peer support, group support, which was fantastic. The group support, they had language-specific groups. So there's large immigrant communities in South Auckland, particularly from Pacific Island nations. So they started off with Maori peer support groups that moved quickly into Samoan and Tongan language support groups, and then into Hindi support groups and a variety of others, which is really, really powerful. They provided self-management education to families and also to what they call the whānau. Whānau is a Maori term that is beyond family, and but means sort of community and family together, and so they looked at that. And they provided case coordination through the peer supporters who were moving from home to home. The results were spectacular. For participants who chose to engage with the peer support group and engage with East Tamaki Health, they saw a 45% decrease in emergency room presentations amongst those with chronic care conditions. This represented huge savings to Counties Manukau, and more importantly, it represented massive improvement in the quality of life for the individuals who got to participate, who did participate in this work. And so this was just a major gain for the community as a whole. And very frequently at learning events and learning sessions, we would have community stories where we would invite people, participants in from the community to tell their story. And one after another to a T, they talked about how this had a profound influence in changing their life and re-engaging them in the life of their families and their communities. And I think that's the social justice story for me that's so spectacular. It has the added benefit of being a great impact on reducing strain in the emergency room and reducing costs and all the rest of those things. But really for these individuals, their lives were dramatically improved. So in this case, the social determinants of health certainly dealt with education, so both health education. It looked really, I think the biggest breakthrough was on social exclusion and inclusion, was helping people to feel a part of their communities again, and to get them together, to let them know that they're not alone. And that's really, really amazing. So there's a lot going on there in that particular example. I'm going to go through one more example. I know we're running out of time quickly, but and we want to save time for questions. But I want to talk about an innovative initiative that is happening in Cincinnati. It's our final sort of case for today of how we can start to think about moving upstream. And for those of you who are familiar with quality improvement, you'll be familiar with Cincinnati because of their children's hospital, which has been a key leader in healthcare quality improvement for the last many years, and a frequent publisher and frequent presenter at quality conferences sort of globally. But this particular bit of work goes beyond just the children's hospital, although it is inspired by and helped, led by the children's hospital there. But Cincinnati is a city, a mid-sized city in the United States. It's based in Ohio, and it's right on the border of Ohio, Indiana, the state to its west, immediately to its west, and Kentucky immediately to its south. Cincinnati is one of those cities that has seen some ups and downs historically, the economics of the city being predicated on manufacturing jobs that left in the 80s and 90s, And so they had a real sort of hollowing out of the city in a lot of depressed areas, a lot of folks who are unemployed, high unemployment rate for many decades. And here you have a city that wants to make a change. And the current leadership of the city, the mayor of the city, has helped to launch an initiative that is focused on having Cincinnati be an excellent place for children to grow up in. And there are 4 portfolios of work. There are 2 that are primarily being led by Cincinnati Children's Hospital. One is the reduction of infant and maternal mortality, which have been quite high in the city. And so Cincinnati Children's Hospital is working very hard on moving upstream into the community to address social determinants of health associated with maternal and infant mortality, including things like access to prenatal care and so forth. There is another one that the hospital is engaged in, which is around improving developmental outcomes for children, and this is a co-partnership between the hospital and the school district, which is focused on developmental outcomes, both mental and physical, for children ages 0 to 5. The school district is focusing primarily on increasing the 3rd grade literacy rate. For those who are not aware, in the United States, our 3rd grade literacy rates are very low. Let me restate that. Let me give you an actual figure. 37% of children in the United States at the end of 3rd grade are classified as literate. That is a major problem, because in the United States school systems, starting in 4th grade, all of your study is predicated on the ability to read. And so all of your sort of coursework now starts to be delivered through books and papers and things like that. And so if you can't read at the end of 3rd grade, you're at an immediate disadvantage for the continuation of your educational career. So that's a key issue, and in Cincinnati, it's a key issue that the school system is working on. But what we're going to focus on today is something called the Child Poverty Collaborative. This is the 4th arm of this major initiative, and it's focused specifically on reducing and mitigating the effects of poverty for children and families. And in particular, it has an aim of trying to lift 10,000 children representing 5,000 families out of poverty in 5 years. And they are defining that as above 200% of the federal poverty line. And so that line varies depending on the number of dependents in a family. So a family of 4 might be $25,000 a year. You know, a family that has 2 people, it might be half that, and so forth there. So this is a very ambitious initiative, and it has only just begun. The team is really actively engaged in the development of theory and are contemplating what are the best ways to think about measuring poverty and trying to understand that. And so I wanted to talk a little bit about how they're thinking about measurement. And we have not come to firm conclusions yet on the measurement system, but these are some of the ideas that people are thinking about at the moment. One is that we would have an understanding and what we would call a lagging outcome measure, one that we can't get very often, which would be the cumulative number of families moved above 200% of the federal poverty line. And so we could think about starting to count that and assessing how many families live below the poverty line and looking at some sort of net figure on an annual basis. But in terms of leading outcome measures, we would look at something like net income as being an important point for understanding. And so in Cincinnati, we're contemplating the use of a couple of different tools. One tool is an income sort of verification sheet that would be used by community-based organizations serving families in communities. And each time they enroll a new family in their intervention pathway, whether that's a housing pathway or a job placement pathway or you know, sort of food security pathway, what a shelter or whatever it is, they would sit down and complete a net income survey, and then they would reassess that every 3 months or so to see if and when net income is changing for a family. And then trying to aggregate that data at a citywide level across the collaborative to understand if at 3 months, at 6 months, at 9 months, are we seeing shifts in income levels for participating families in the community-based work. There's also another tool that the team is using called a ROMA tool. It's very similar to the North Carolina Family Assessment Tool, but is a tool that was created at the federal level in the United States government by our Housing Authority. And it looks at trying to understand family stability through a variety of what we would consider process measures or process metrics. And so again, every 3 months or so, we would be understanding housing stability, employment stability, access to child care, et cetera there, and looking to see if we're moving the needle on those things. Appreciating that moving families above poverty, nobody's really sure if we can do that. We're not really sure if we know how to do that. We're taking on an ambitious aim. What we do feel much more confident of is that we can move the needle on family stability, and that families that are more stable, more predictable are going to end up in a situation where they have better health outcomes, they have better education outcomes, and perhaps over the long term that will result in less families in poverty. And so our focus really is on the production of stability in order to achieve a movement in poverty. And that's the theory. That's the theory at the moment. We'll see how it goes. A couple of other things that are really interesting, aside from the content improvement, we're also contemplating a couple of other types of measurement. So there are a variety of community-based organizations. I think we have more than 24 at the moment. And so we want to understand, as we teach them the methods of quality improvement and improvement science, how well they are using those. And so we'll be looking, for example, at the use of project progress scores. We'll be looking at the number of PDSA cycles that they're running. We'll be looking at the number of team meetings they're having, their participation in various learning events, and so forth, to understand engagement with the improvement journey. And that's really important for us. We have a strong degree of belief that community organizations, community-based organizations that serve people living in poverty can get better at doing their core service. And so that's a big part of what we want to do. The other thing that we want to understand is the connections between services. So taking a page out of the Helping Families initiative, we want to understand what closer to each other in relationship, because we understand that families have multiple needs happening simultaneously, and to serve those needs in series is often problematic for families living in poverty. So, often what happens is a family maybe has an emergent housing need, they get emergency housing, they solve that problem only to lose their job, or only to have a criminal prosecution, or to have their car break down, or to lack child care that prevents them from working, and so forth. So often we need to have things working in parallel. And so we want to understand the ecosystem of the community-based organizations in general. And so we'll be measuring network engagement and how frequently organizations are interacting with each other in meaningful ways. And so that'll be a third aspect. And so that'll be important here. I see a question here from, I think it's Adrian. With this measurement framework, are you considering capturing qualitative information? And that's a great question. I think we are considering that. We don't have a formal qualitative plan yet, but I think that is something that we need to consider. But I think where we do try to understand that the crossover between qualitative and quantitative is really through the ROMA tool, which is a co-created understanding of where families are at between a provider and the family. And the scales are qualitative in nature, and so we sort of have people self-identify where they believe they are based on the stability scales. But I think there's more we could be learning and more we could be exploring in that regard. So our work to date is that during the last 8 months or so, we launched a breakthrough series style collaborative to drive initial engagement. And the idea there was to orientate community-based organizations to the ideas of quality improvement, to get them thinking critically about their systems and about how they have designed their processes of intervention, and to partner them with local quality improvement coaches. Through the United Way that has been leading this work in Cincinnati, we've reached out to industry, and we've had more than 10 quality improvement advisors or quality improvement coaches from industry who have volunteered their time to coach community-based organizations, which has been fantastic. So we'll see, for example, process engineers from Dow Chemical who say, you know, in my free time, I want to be here, I want to be doing this work. And so I'm gonna donate an hour or 2 hours a week. In some cases, we've seen corporations say, you know, you can have a day a month of our quality improvement coaches' time in order to help coach these folks. They have a vested interest as being community members themselves, and so it's been a fantastic form of partnership. Well, in terms of results, we don't have any yet, so it's really about future work. And our future work is likely to include really 2 or 3 main things. One is an innovation lab focused on testing change ideas around how to better serve families living in poverty. So that'll be organization to organization. A connection lab that will look at how we foster the parallel connections, the sort of warm handovers, if you will, from organization to organization. And then utilization of our coaches to continue their involvement with CBOs that historically have not had access to quality improvement consulting or advising or coaching. And then for the collaborative as a whole to advocate at the policy level right in the mayor's office and at the city council level for where policies in the city might need to change in order to better serve the community. So it's an open question. I think we're going to learn a lot what's going to happen. I'm confident that at very minimum CBOs will start to get better and more efficient at the provision of their services. I guess I'm hopeful that we'll go even further in terms of generating stability for families. It's very, very ambitious and it's very early days, but I wanted to give you a sense of one city that is trying to move upstream as far as it can in order to prevent those downstream issues of chronic care, acute care, crime, and a variety of other social ills that can be very, very tough on our community systems. All right, I'm going to stop there because we've got 8 minutes left, and we'll move over to questions. So please throw them into the chat box or speak them out. I don't know if we have that ability, but what questions do you have?
Hi, Brandon. This is Chelsea of the Health Quality Council. We have a question from Sherry Furness, who's in the room with us as well.
Good morning. So thank you so much for the presentation. Lots of really interesting, diverse projects. So, you know, one thing I noticed is you aren't taking on small projects. They're like really, really big in scope, very complex. You have lagging outcomes, which says to me you anticipate that it's going to take a while before you really do see those outcomes change. So I guess I'm curious, like, when you look at the timeframes of the projects, what does that look like, and how are you keeping people engaged? Because I know there's always lots of excitement at the start, but when you have that longer time period, you know, how do you keep the momentum going?
Well, you don't ask easy questions. Yeah, I think you're right. So these are relatively big things. It's a very interesting conundrum because traditionally in quality improvement, we do like to start small and solve for one. I think a good example of where we have been able to do that is the Helping Families initiative. So we started first in a single judicial circuit and with, you know, one social worker working with, you know, 1 or 2 families at a time, refining the intervention. And that took many years. And it took probably 7 or 8 years before we had any sort of inclination of initial results at scale for the single judicial circuit. So now it has become a problem of scale as we have gotten to a place where we know what to do. In Cincinnati, this is, you know, it's a different situation. Starting small is was never presented as an option. partially because it's coming from a political perspective and it's coming through the mayor's office. So part of keeping people engaged is keeping them involved in the political process, keeping them at the table, giving them access to the political leadership in the city. All of those things are very, very important. The other thing that has been used as a lever in Cincinnati is access to funding. So the community-based organization space generally suffers from a lack of funding. And so what they have tried to do, both in Cincinnati and in a couple of other communities where I've worked on similar initiatives, is pool and leverage funding sources to keep people engaged. To basically say, if you want funding from, say, the United Way, then come through this process. Come through the Child Poverty Collaborative and work through this initiative. And, you know, some of the caveats are that, you know, we want to give you a quality improvement coach and we want to give you some training on the use of quality improvement tools. And in doing so, you know, the trade-off is you'll get funding for your programs. And so that's sort of a lever that's been utilized for better or for worse to sort of keep people engaged there. But the idea of scale is a scary one. I do think when addressing issues of poverty, sometimes we have to think at scale because we're talking about some macro levers that exist in our communities. So we have to kind of be thinking ahead to that. But I still think there's room, particularly at individual community-based organizations, either within themselves or between each other, to practice improvement on a small scale. So how do we get 3 or 4 or 5 community-based organizations to have a strong referral network between them for the parallel service provision? Well, we could start with one family, and how could they figure that out for a single family, and then we could scale up from there. So there's opportunities to go small while still thinking at a macro or a big level.
Great. Thanks, Brandon. A nice kind of segue into our next question from Francisco from Manitoba Health. He shared some reflections at the front end, and then the question is, what are the challenges of scaling up to a system redesign level with some of these intersectoral improvement initiatives? Yeah,
that's a great question. So I think, you know, let's take Alabama, for example. The challenge has largely been funding and political buy-in. So there's 2 things that are necessary for the spread of the Helping Families Initiative in Alabama. One is that district attorneys, which are basically the CEOs of judicial circuits around the state, have to buy in that this is a good idea. And as I said at the start of the call, many district attorneys are historically, traditionally, very conservative. Their job is to prosecute the law. And so there's lots of district attorneys who do not see their job as preventing crime. Their job is to prosecute criminals once a crime has occurred. And so they don't necessarily place a high value on embedding a social worker and a social work process within their offices. So that's sort of a political or a will-based issue to begin with. The second is at the state level. So judicial circuits are funded by the state legislature. And in Alabama, which is a very conservative state with a lot of conservative values at work in the political environment, there is a reluctance to fund social welfare type services in this way. And so there's limited funding for that. And that is a major issue for moving to scale. So of course, the Helping Families Initiative looks at seeking outside support from as a grantee from various foundations, and of course is always lobbying inside, particularly by trying to demonstrate results, which do align with the long-term sort of outcomes and values that the legislature might be interested in achieving. I think very similarly in Cincinnati, you know, there are these sort of questions of political stability. So this is all being run by an individual mayor. And that mayor just went through a re-election campaign that ended in November, and that particular mayor was re-elected, but it was unclear for a time. And so as community-based organizations, for many of them sort of sat waiting and wondering, will this initiative continue? You know, that was the case. And so I think these are types of things that as you go to scale, you start to have to think more critically about. How do we maintain political continuity? what are the policies and the policy environment that will empower or disempower the work? It's a great question, very, very difficult, no easy answers.
So I see that we are at time, and we also have one more question that has come in. So I'll invite folks who are able to hang on with us to just hang on for a couple more minutes and allow Brandon to answer this final question. Go ahead, Brandon. So from Jody Mara from here in the province, in the, was it
Kaha? Yeah.
Kaha initiative, it was apparent that an improvement in health outcomes was evident. What was the role of cultural competency in program design?
This is a wonderful question. So I would say cultural competency played a leading role in the work. And essentially where this began was with two peer supporters, both of whom come from the Maori community, one of whom is a person who suffered many years with chronic care conditions and herself had suffered from clinical depression. And after working with a local psychologist embedded in the primary health care space, they sort of said, could I, her name is Merle, she said, could I reach out to my, my fellow community members? I want them to have what I now have. And that was where the initiative really, I think, really sort of got its spark. And so I think coming from inside the community of need is a really, really powerful thing. And then, of course, having that Maori perspective from day one made it culturally relevant and culturally acceptable, which was incredibly, incredibly important for the success of that program.
Well, thanks so much, Brandon, and thanks again for taking the time to share your wealth of information and experience with us on the call today. I think that locally we have lots to think about in terms of how we can begin to bridge some of our sectors locally. So just by way of wrapping things up, I'd like to thank everyone for their participation on the call this morning, and we do hope that you'll join us next month for QI Power Hour. We'll be back on April 27th with Dr. Cheryl Mills, educational design consultant here at HQC, to talk about the drama triangle. Do you find yourself or members of your team or even your family members caught up in blaming or gossiping or criticizing or catastrophizing about something or someone? You or someone else could be on the drama triangle. So we invite you to join us next time on QI Power Hour to learn a bit more about that. And we also welcome you to provide your feedback on today's session by completing the survey that will launch when you close out of WebEx. We appreciate your feedback and look forward to connecting again next month. Thanks, everyone.
Thank you, everybody.